so that everyone can join. Okay, it looks like we can start. Welcome to the Healthcare Lounge. Today's session is titled NEXTGEN Benefits Health Plans, a Clinician's Perspective. So now I will turn it over to Nelson.
Thanks, Kendall. Welcome to the Healthcare Lounge. It's a pleasure to have you here, and I've got a very special guest today in the lounge with us. Many of you will know her. She's going to be preceded by her reputation. Our guest is the legendary Cristin Dickerson, the co-founder and CEO of Green Imaging, which I continue to describe as a true Uber of diagnostic testing, where Cristin and her team are using unutilized resources or a capacity at imaging centers around the country, and then connecting that unused capacity with employees, patients who need diagnostic testing, connecting them through technology, just like Uber, at a tremendous savings and a terrific efficiency. So we are going to talk today. Let me bring Cristin up and centered. There you are. Hi, Cristin.
Hi.
It's always good to talk with you because, first of all, you've done such great work with Green Imaging, and I think it remains the gold standard for cash price bundled diagnostic testing. But you bring a clinician's perspective to the next-gen healthcare ecosystem, our processes. You also have a unique perspective as a solution provider who interacts with other parts of the ecosystem, TPAs in particular. And so what I wanted to talk about today was what can we learn from your perspective about the broader ecosystem, and then some of the lessons you've learned about the integration of cost containment solutions into that ecosystem. You know, when it's a fully insured plan, it all happens in a black box, and we don't know if it's a fully owned subsidiary of the BUCA that is doing medical management, or if it's the TPA or they're outsourcing. Doesn't really matter as far as the patient knows, the employer knows, the broker knows. But when we're doing unbundled, there's much more transparency, not just around cost and quality, but also around the components, the players, the solution providers. So what kind of lessons have you learned about the interaction of those solution providers in a next-gen healthcare ecosystem?
Well, I think the biggest challenge is making sure that those solution partners understand and have created workflows together. Where we run into trouble is when we're not interconnected. And so, with we built a portal for navigators last year. And we've been implementing that with our navigation companies and medical management companies that we work with. Because one of the things we saw was that we were butting, everybody was on the patient. Everybody was, trying to take care of this patient. And we were kind of butting heads, not butting heads, but just bumping into each other. And so it really created a clear path for them to be able to somewhat self-serve, see what our pricing was, see what our, where we had availability. But also to provide us the information we needed and, get updates on where the patient was without as many phone calls and without as many, personal interactions. And that has really been a wonderful system. And it's decreased our overhead, and I'm fairly certain it has for our solution partners as well. So that's just an example of where together we're better. When we listen to them, we find the points of friction, and we create solutions together that get, so it is the friction points that we have to be alerted to and aware of. And they're all throughout healthcare. It's not unique to a NextGen plan compared to a Blue Cross Blue Shield plan. These are problems that are ubiquitous. Are they solvable? A lot of them are. And but it takes the right people, it takes the right technology, and it takes, I think, people thinking about this as a new healthcare economy. How do we change the economy of healthcare so that it's better for employers, better for members, and the money is well spent, not just wasted away on trying to create technology solutions, because they certainly can, when done properly, be the way that you solve friction.
You bring up a great point, and like you, because of the seat that you're sitting in, you see some of what everyone or everyone should be seeing, but I don't think they are. I see it globally and universally, the user experience that we're providing patients in our next-gen healthcare ecosystems, our next-gen healthcare plans. And it's often not very good. In fact, I think many times it's worse than the BUCA experience. Now, the employees are getting better health care. They're paying less for it. The employers are paying less for it. So overall, it's a huge improvement. But the UX, user experience, the UX is actually not as good. I think a big part of it is we're still trying to figure out how do the component parts work together to reduce, and you use the word, and it's a fabulous concept, friction. And friction doesn't just prohibit or prevent smooth engagement and smooth interaction. It also kills sales. So when one of our advisors is talking about to an employer about self-funding, that employer is thinking about the friction that moving from fully insured to self-funded would cause. And some of it's fear. The acronym FEAR is an acronym for false evidence appearing real. Oftentimes they're wrong. They don't understand self-funding when it's done right. There's no more financial risk than if it's fully insured. But they are worried and they have these concerns. That's friction, and that friction prevents the sale. Well, in the same way, friction prevents you from doing your job as well. And ironically, you alluded to this. It's not just the job you're doing, but it's your profitability. So as a solution provider, you're not as profitable because of the friction out there. So you get rid of the friction, everybody wins. What are some of the improvements you've seen in the interactions between your services, your program, and let's say TPAs in the market?
I think it's building the relationships with the TPAs. I've really focused personally my last year and a half on working with the TPAs, finding a representative at the TPA with whom I could build a relationship and start to work together to cut through. One of the biggest points of friction, Nelson, is the differential between plan design and our contract. Maybe it's our contract, AIM's contract with the employer, maybe it's Green Imaging's contract with AIM, but we run into plan design issues. And we also run into infrastructure issues. One of the things that's changed since I founded Green Imaging is retro terminations. In the old days, terminations happened at the end of the month. If somebody left a job or left wherever they were, their insurance would terminate at the end of the month. Well, now there are retro terminations where your coverage can stop even before you leave the job or on the day you leave the job, or if something wasn't funded properly, if your employer didn't fund, didn't pay properly, then the whole group is retro terminated back to the beginning of that month. And with imaging, where we're scheduling an exam, sometimes, a week or 2 weeks out, sometimes longer than that for a mammogram, that is a huge issue. And so, aligning plan design with how we get paid and how we can confirm, because the portals that the TPAs have frequently don't get updated as frequently, or, we have them send us a census monthly to show verification. So, there are issues there. There are issues with plan design where, our agreement says we're going to cover medically necessary imaging, and yet somewhere in the plan documents this is my classic one where they exclude foot disorders. And so it was actually an MRI of the ankle, not the foot. They had an anatomy issue and a plan design issue, but they denied the MRI because foot disorders were excluded. And so, and I say, kind of the foot bone is connected to the ankle bone is connected to the whole rest of the body. I don't know how you can, but it's a pretty frequent finding in plan design. A couple of your advisors sent me their plan documents to look at, and I found it in 2 of them. So it was very interesting to see that. It's a common exclusion, I think, because people want to do cosmetic some of the things that people feel are cosmetic, are associated with feet, but I guess, but if you have a hammer toe, makes it hard to walk and get exercise and get cardiovascular, it's all tied together. So I think I would say that plan design is a place that we've been trying to work with, and I'm on that validation institute board where we're looking at the educational materials for the validated advisors, and really get into this clinically appropriate plan design, so that this kind of thing doesn't happen, and we're all on the same page, and we're all rooting for the patient's best health.
One of the mantras in NEXTGEN Benefits is to a broker who is entering NEXTGEN, wants to become a NEXTGEN Benefits advisor, is that you're no longer in insurance. What do you do? I sell insurance, healthcare insurance. It's like, no, you're no longer in insurance. You are in healthcare.
Right.
Now, you're not a clinician. You're not providing care, but you are facilitating the delivery of care as well as the financing of care. But the financing part's kind of easy. It's either fully insured or it's self-insured. If it's self-insured, are you going to pay the contributions as incurred, claims incurred, or level funded? But that's kind of easy. The challenge, and understand, Cristin, I think you know this about me. I fly at 40, 60,000 feet. And that's really what my job requires, because I've got to see the entire picture. And if I get too granular, if I get too much down in the weeds, I get bogged down, and I get, part of it is I get like, oh my gosh, this is so freaking complicated. Well, it's not complicated, it's complex. But I don't need to deal with that complexity, but advisors often do. And so in looking at plans, what are some of the observations that you've made as a clinician? Not necessarily around diagnostic testing, but you've got a keen eye for what's going on. You're very observant, and you're very analytical, being a scientist. Where else do you see the clinical side of the equation sort of flaring up around plan design or implementation? I'm talking about, let's say, enrollment, educating the employees, et cetera. But the clinical piece is where it's almost a gotcha, because we don't know to look for that. Secretary of State and Defense, former Secretary of State and Defense, once said there are 3 types of knowledge. The known, I know what I know. The known unknown, I know I don't know that. I know that's knowledge and I don't know it, and I know that. And then the unknown unknowns, this is what you don't know. You don't know it exists. And his point was the unknown unknowns are what come around and bite us in the rear, because there's no defense for it. We can't be ready. We can't get ready because we aren't aware of it. What are some of those unknown unknowns that you've seen pop up in plan design or other aspects?
I would say there's a little bit that we know about it, but there's a much deeper dive into it. And that's the HSA plan, the Qualified High Deductible Healthcare Plan. That's where we are seeing a lot of friction right now. And yes, they are they have somewhat failed as a consumer vehicle. They are a wonderful thing if people would use them as intended, which is to some degree employers funding them. So there's actually care that can be acquired. And the other is that members are funding them and they can use that savings vehicle and they can take it with them. So there's some really good things about it. Another is that those are the cheapest plans, at least in Texas. And so they can serve as a truly catastrophic health plan, which is great. The problem is the first dollar exclusions. And that's where all these people who want to put the zero out-of-pocket options in place run into, uh-oh, I've got 10 members over here on the HSA plan. What do we do with them? And there are lots of solutions for that. There are actually, I've got a list of 6 hacks for how you do first dollar coverage with HSA plans. And, there are a number of really brilliant ways that people are doing this. Number one, I have an advisor out of Houston who offers 2 different plans that are as similar as he can get them, that are qualified high deductible healthcare plans, but he only qualifies one of them. He only enables the HSA for one of them. So that plan, if you opt into that, you get the catastrophic plan and the zero out-of-pocket options. If you opt into the one with the HSA, then you are subject to the terms, the first dollar exclusions, but you have that savings vehicle. If you're somebody who wants to put money away on that and really understands the concept, you get the benefit of that. I think that's brilliant. I think it's a really good way to do it. We have another TPA that actually W-2s the employer goes ahead and funds the zero out-of-pocket option. And the nice thing for the employee, they're getting that care they need. They're not having to come out of pocket, $425 for the MRI, and they're only going to bear the tax burden of that. So it is it's a taxable expense. So they're going to pay the income tax on that. So if they're in the 20% tax bracket, they're only going to pay 20% of that care. They're not going to pay for the whole thing. And so that is another strategy that you can use with an HSA plan. There are limited use HRAs that can be enabled for this. There are lots of different options. And I really think that that's something that advisors, if they're going to use these vehicles, they need to be familiar with those, because it's gonna be tough for any solutions to offer this kind of care. And you know me, I'm all about reform. I'm about transparency. And I'm about, medical debt has been abused, by hospital systems in this country. We got a problem though. We have dwindling number of independent physicians, and this new legislation that's going in place is going to keep us from being able to collect from a patient after the fact. We are not going to be able to go after a patient. We can only call them once every 45 days, only if it's over $500. And it's just, I don't know how independent practices are going to do that. If they get it, say they accept traditional insurance, somebody turns down, the insurance company says, nope, this person wasn't covered. They had some other primary insurance, whatever. The practice can't go after that under $500 expense. And so I understand that, there have been bad practices in place collecting from patients, but it's really, really going to kill independent practices. And so, so what they tell us, a lot of times, we can't see in the portal that it's a qualified high deductible healthcare plan. They say, oh, go collect from the patient. We're not going to be able to do that. And so that's where it's really important that advisors understand the strengths and limitations of these plans.
So this amount that physicians are going to be unable to collect under 500, is that a balanced bill or is that deductible?
That is, it could be deductible. It could be a copay. It could be any number of things.
So is that not going to lead to pre-service collection?
Well, it does lead to, we do pre-service collection. You only collect 6 cents on the dollar from a patient after the fact.
Right. But I'm saying it's like, we need this. We will not provide the service until you've paid this.
Right.
Right. So, that's the answer, is it not? From
it is the answer if you can
identify
which patient that is. The problem frequently is that you don't know which if there's a mix in a health plan of a patient who's, got the PPO and is getting zero out of pocket, and there are 10 of them with the HSA, you'd be surprised at how many TPAs don't have a mechanism for telling which those are. We had one that it was a horse breed. If you were a Shetland, you were an HSA plan, and if you were something else, you were a Palomino, you were on the PPO. It can be that interesting.
So it seems to me that by the way, I love HSAs as a savings vehicle. In fact, it is the most tax advantaged
Right.
savings vehicle on the planet. There's nothing better. If you've got money to sock away, fill up your 401k and then start stuffing money as much as you can, max out every year in your HSA. But as a cost containment or encouragement for consumerism is a failure. It doesn't work.
Absolutely.
I don't even think it would work if you had all of the data available, all of the quality and cost data available, because when you are sick or hurt, the last thing you're really interested in is research, number one. And number two, unlike televisions and cars, there's really no guru that you can turn to. I mean, the Best Buy salesman's not a guru on TVs. The car salesman is not. You've got magazines you can read, of course, and Consumer Reports, et cetera. But when it comes to your health and to medicine, there is a guru. She's called the doctor. And people will simply repair to the expert and say, what do I need to do? And so they're not going to shop around. They've proven that. I just don't think it's going to work. Hasn't worked so far. So, I mean, so where do you come down in terms of HSA or no HSA when the employer and the employee have an opportunity for zero out-of-pocket health care at a substantially lower cost for all parties, not just the employer?
I think you reduce friction by having a single plan design in the setting of a NEXTGEN type of solution. I really do. I think you need simplicity. That's the biggest problem with healthcare is healthcare is complex in and of the scientific end of it. The business end of it doesn't have to be so complex. We can set a price, somebody can pay it, we can get the middlemen out of there. There are all kinds of payment vehicles now where you don't even need a TPA. You can pre-fund. There's so many different options there. Why are we creating this complexity?
And I saw you just registered yes for our Phoenix Mastermind Summit in September. We have a tour scheduled of one of the most advanced orthopedic ambulatory surgery centers in the country, the Scottsdale Center for Robotic Surgery. And not only are they extremely advanced from a technology standpoint, but they are also cash pay, bundle price surgeries with the prices posted, just like Keith Smith at Surgery Center of Oklahoma, posted on the website. And it doesn't get much simpler than that. It's like, yeah, well, what we do in the OR, that's pretty complex, but the business side of it, the transactional part does not have to be. You've made it very simple with green imaging, incredibly simple. What exam do you need? Where are you? Here are your closest options and the prices for that. And it's in the documentary, the new documentary, it's not personal, it's just healthcare. Deb Alt makes the point that what they do at AIM is help handhold employees through the two most confusing and complex ecosystems in the world, the insurance ecosystem and the medical ecosystem. And that it's very true. So the simplicity we can bring, and I think giving two options. Look, HSAs were a fig leaf for high deductible plans. And let's face it, it's, oh, we're gonna jack your deductible up. Oh, we'll do an HSA and throw a little money back at you and you fund the rest. Good luck with that. Moving on from HSAs, what else do you see where the plans are not quite getting the medicine right?
Well, I think I think what the trends that I'm seeing that are the most beneficial right now are navigation and the advanced primary care. And, you know, DPC has been our kind of mantra, but DPC is expensive as it, you know, truly morphs into, you know, individualized healthcare. There are forms, you know, of subscription-based healthcare that are more affordable for health plans, and that can have similar opportunities for shepherding a patient through the healthcare process. So I think those are the two things that we're really seeing that are successful. I think the next big step is getting all kinds of doctors into the ecosystem. And I spoke a couple of weeks ago at the University of Houston Grand Rounds. Their new medical school had a Grand Rounds, and I spoke about basically, you know, new models for physician compensation, because we have to think of ways that we can get doctors into this ecosystem without a huge financial commitment. You know, you can start tomorrow. You can start accepting, you know, post some rates. But, you know, there are different models depending on the kind of physician you are. You know, if it's primary care, subscription-based. Actually, if it's chronic care, subscription-based works really well too. If you see your cardiologist every 3 months, if you see your rheumatologist, if you see your endocrinologist every few months, that can work really well on subscription care. And again, it's aligning the ethics. It's that doctor doesn't want to see you 10 times during that quarter. The better care they take of you during that appointment, and the more that they make sure that you're doing what you're supposed to be doing on a day-to-day basis, the better off they are financially on a subscription-based plan. So I think that is an amazing opportunity. But then there's episodic care, which is like green imaging or like the ASC. And there are other, you know, doctors who see patients on a one-off basis. That is a really expensive thing to do on a business to consumer level, because, you know, we're not going to see that patient repetitively. They're not going to be paying us, you know, every quarter or every month some fee. So episodic care is a little more challenging, and that does require, I think, the business to business kind of relationship. And that's where I think health plans have to engage the episodic doctors in care. And then, you know, I think niche care is the next hot thing in healthcare. It is becoming overwhelming for physicians to keep up with data, the emerging data, the emerging technologies, the things that they need to know about. So I really see for the future niche care, where I become you know, and it's already happened to some degree with subspecialization, but I think it's going to be even more niche than it is right now, where maybe I'm an oncologic radiologist and I, you know, trained in oncology and I know a lot about a lot of different cancers. I think it may come down to being a specialist in specific cancers or specific types of cancers. And that's where I see an opportunity in primary care, in secondary, and in chronic diseases as well, for doctors to create really niche practices that really cater. They have the knowledge base that's, you know, specific to that disease state, and they know exactly the best way to engage those patients and keep them healthy and, you know, and engaged. And I think that is a tremendous opportunity, especially for young doctors. But those of us who've amassed quite a bit of education over the years too can do that. But I think that's one of the future trends is becoming, and then offering yourself to health plans for that specific you know, item at a much lower cost, because you are specialized in that. It comes down to just like the surgeon who does, you know, 8 knees a day provides better care and is more efficient. You would be much more efficient at treating those patients and much better at treating those patients. So I think that's going to be another thing. And again, that can go back to subscription-based. There are lots of different ways to do that. So I think we really need to be focusing on bringing more and more physicians in, and not, you know, not hospital systems, because I don't think that's where the value is. Bringing more and more physicians into this new economy. It's better for them and it's better for the ecosystem. And actually, I'm on the Texas Medical Association just started an independent physicians committee, and I was asked to serve on that committee. You know, that's really exciting. I'm speaking at the National Conference for the American Academy of Physicians and Surgeons. I find myself kind of coming back into mainstream medicine now after, almost 15 years of being out of it. But there's really a need for this in the physician community. They need to see a way out of the broken system as well. And so I see that as, tremendous opportunity.
Well, you may be re-entering mainstream medicine, but you're bringing a big box of hand grenades with you. So you're going to disrupt. I'm sure some of them are going to go, "Why in the world did we invite her?" And others are going to go, "Why haven't we heard from her earlier? Where has she been?" So let's see. What are you seeing in terms of receptivity out there? I mean, I work with a large number of advisors, but it's a small number in the overall scheme of things. I know you're working with brokers and advisors outside of the NEXTGEN ecosystem, the Rosetta ecosystem. There's more and more overlap between Rosetta and NEXTGEN, which I find really encouraging. We just got a application for our mastermind group from a longtime Rosetta advisor who's been doing great work, but wanted to get involved in our world. But outside of those two groups, where they're pretty knowledgeable, like educated, what are you seeing from the more mainstream brokers? Are you getting any interest? And I say you, I mean, of course, Green Imaging. And what does that look like? How are they fitting you into their plan designs?
What we're seeing, Nelson, is really interesting. We're seeing the employers saying, "I want green imaging in my plan. Make that happen." And as we know, they have a disincentive because it's going to pull a significant amount of money out of the plan from which they're taking a commission. Without a more appropriate reimbursement, a more ethically aligned reimbursement, that certainly can hurt them economically. Although on the other hand, they want to keep their clients. And so that's really, I would say that may be the next trend, Nelson, is individual employers really, bringing the more traditional brokers into the arena. If they want to keep their clients, they're going to have to stay up with the solutions that are out there working.
I can think of two companies. One, Dan LeBroad was talking to the CFO, Dan LeBroad Ovation out of Dallas, and he said, "Did you tell me about your health plan?" This, I think, was a social event. I said, "Tell me about your health plan." He says, "Well, we're doing reference-based pricing." Dan said, "Well, who in the world who put that in? There are not that many of us out here even aware of reference-based pricing." He says, "Oh, my broker didn't do it. I researched it and told my broker to do it." And another employer in Michigan, Michael Lutz's client, Michael with Compass Advising, the CFO said, "We're in a captive." And Michael said, "What? Which broker put you in a captive?" He said, "Oh, no, my broker didn't put me in. I told my broker."
Right.
We researched it and decided. So I think there is certainly that potential. The challenge I see is there are some really good HR directors when it comes to being innovative. They are innovators on the change adoption curve. They're on that very front end where it's almost a flat line. There's so few of us and so few aggregating to hit until we hit the early adopter stage where the curve actually goes up. But those HR directors are few and far between. And I think employers who are willing to look into it are few and far. We're hearing about them. You're hearing about them because they're the few that are saying we want more. My hope is that they'll start talking to each other. That becomes somewhat viral in the CEO, CFO community, in their market, in their town. Are you seeing any innovations that are new to you in terms of plan design or cost containment strategies?
I'm seeing a trend, which is even the strong proponents of RBP are moving to direct contracting as the primary, using RBP as the kind of backup plan and moving to direct contracting. I think there are two factors there. Number one is the the noise that goes with reference-based pricing, and the fact, and then part of that noise is just that if I'm a traditional doctor's office, I'm taught to look at the benefits card, and if I see something that doesn't have a network that I recognize, I'm going to say we don't take your insurance, and that's hard to empower employees enough to advocate for themselves in that setting. So that's part of the noise, is just access to care. But I think the other factor there is that, routine. I mean, if you look at what a traditional experience in healthcare is, it's 2.8 Google stars. And now you've got emerging solutions that have, we carry 4.8. We have real reviews. If you're 5.0, you're not getting real people in real healthcare reviewing you. But we have 4.8 Google stars. And when you can get that kind of care at the same price point, why are you doing RBP? And I think RBP is great for the rural patients who only have access to, to a rural hospital, for emergency care. All of those things are great. But I think what I'm seeing is the strongest proponents, and who some of those are moving to direct contracting. And that's the biggest trend I see in that kind of payment space.
All right, that's of course should be fascinating for anybody who's listening. I have said from the beginning, RBP is great because RBP works.
Right.
It's why it's one of the few cost containment strategies for which you get decrements from the stop loss underwriters, because they know if you're going to put in RBP, you will save money. At the same time, RBP is a Band-Aid on a cancer.
Right.
And the cancer, and the Band-Aid works, it does reduce cost, but the cancer is a bad network contract that the insurance company wrote for the providers. And so, and if I were a hospital, well, look, you're a provider. If you have a contract with me and you provide service and I go, oh yeah, well, we're not going to pay you what the contract requires, that's not fair. We're going to pay you less and you're going to like it, or sue us. We don't care. How angry would you be? And you have every right to be. You have a legitimate contract.
Multiplan's been doing it for 25 years. So
fair enough. So you don't like it. And you shouldn't like it. A contract's a contract. Just because we can break it doesn't make it right.
Right.
It's our only recourse until we write a new contract. So what do you think is behind that? Besides, the noise has been there for a while. Are you seeing advisors developing these direct contracts, or are they using third-party vendors who are establishing the contracts and then they're taking advantage of them?
I think the third-party vendors, on an individual basis, it's hard to get good data. It's hard to get quality data. It's hard to, I think what we don't want in healthcare is middlemen who don't bring value. But aggregating, driving down cost, making sure the quality is there, that's bringing value to advisors and to health plans. And so those are the kind of middlemen we really need in place. And I see, there is a movement now. A lot of this is private equity backed to move toward more integrated solutions where they're actually buying solutions and cannibalizing them and offering them in a more single product, or creating health plans. The jury is out for me. I don't think the private equity doesn't have the that kind of ethical alignment. They're in it for the investors, and if you can do that and still hold down the cost enough, to make it a better product, maybe there is some efficacy there. I think the jury's out there. The health plans, there are some very interesting health plans out there. I would say, Curative, Decent, Sana. They're doing some things that are using NEXTGEN type strategies and pulling them together in more formal health plans. And so I'm going to be interested to see kind of which of these trends is better. There are other solutions out there that are aggregating, but they're not cannibalizing. And I really like that best because I do think that, like, Nurse Deb can't do what I do and I can't do what she does, but we're both really good at doing what we do. And so I think when you can bring kind of the best solutions together without cannibalizing them, you are in a really nice place. And especially when they're solutions that know how to work together. And that's what you're doing with the NEXTGEN plans.
You raise an interesting point, which is you see some solution providers acquiring other solutions to create a vertical product. And I think the problem with that is you're capable in all, but you're excellent in none.
Right.
Right, because you've got the same management overseeing all of them, whereas before you had, you had a radiologist named Cristin Dickerson overseeing a diagnostic imaging solution. But if you are then marrying that with a medical management team, a medical management solution, and that's being married with an RBP solution, which is being married with a direct contracting solution, it's like, where does the expertise lie? You can't be good at everything, just like hospitals can't be good at everything. This is why specialty hospitals exist.
Right.
MD Anderson, cancer. We don't bring your knee to us. We don't know about knees, but we know cancer. But the broader hospitals, they're going to be good at one or two things, hopefully, but not so good at others. By the way, if you have a question out listening to us, don't wait till the end. Go ahead and put it in the Q&A box. We've already got some really good questions. I'm going to repair to the Q&A because I want to get some of these in. I just want to acknowledge Paul Hacker makes the point, and I want to make it because I want to reinforce it. His point, I do agree it's your doctor who helps direct your care, he says, if you can get in to see your doctor. The fee-for-service model is not working. Unless you're in a DPC model, it's not going to work for you. Primary care doesn't work very well. So in our NEXTGEN Benefits Boot Camp a couple of weeks ago, Cristin, we had some advisors from Wisconsin, and HMOs are huge in Wisconsin. When one of these advisors needed shoulder surgery, I think it was 6 months before he could get in. And when he did, the quality was not nearly as good as when he went to Indiana, is it shoulder and hand, I think, cash price, bundled surgeries, and got in within a couple of weeks.
Right.
So it's sort of the same thing when the incentives are aligned properly, higher quality, lower cost, and usually better access, easier access.
Right.
Bill Schmaltz said, is it possible to carve out some facilities in the network, such as hospitals? And my experience and everything I've heard is no, the network will not carve out any of their providers. Have you seen any different?
Are you talking about I don't know if he's talking about my network or hospital.
Oh, I think he's talking about, hey, Bill, you want to clarify, are you talking about Green Imaging's network, or are you talking about a PPO network? Just.
I think one way to.
Oh, your network, Cristin, your network.
Mine specifically, we do have the technology to do that. And the problem is some exams are only offered in a hospital system. And there are two reasons we've started working with hospitals. Number one is they're struggling with patient responsibility and they're really open to working with us now. And in some geographic areas, there's nothing but a hospital. And number two, some exams are only offered in hospitals. And when we have a bundled, I would say a pediatric MRI is going to be a lot of pediatric exams are only offered in hospitals. We primarily use our outpatient imaging centers. The access is better. It's easier on patients. It's much easier on us. Believe me, we avoid the hospitals where we can. But, and we do have the technology to exclude that. I think another way to do that in any network is to have a safe harbor, where if they go to a hospital system, they're going to be subject to something. If they go to this specific hospital that you have an RBP, type pricing with, it's zero out of pocket for them. So I think there are ways. Again, I do think that right now the best ways to incentivize members to go somewhere is going to be, financial incentives, and they're huge now. I think members are starting to get a few years ago, nobody got that, an ultrasound was going to be $600, $700. Well, now it's $1,300. The financial incentives are working a lot better now.
Let's see. So that's answered. Bill Schmaltz, and I should say one of our mastermind partners, Bill Schmaltz out of St. Louis, Einstein Consulting Group. Bill asked, does green imaging provide savings reports to advisors to help with reinforcing the value? And I'd bifurcate that question. Do you do a report based on claims data showing the savings that could have been had? And then do you provide like case studies or data for a client to show the value that you've brought over the previous 6 months or a year?
Absolutely. And we love to do it. We very much want to do your claims data assessment. We have a template for that. Our method of doing that, we run some code, but it is Validation Institute validated. It is very conservative. So I'll give you an example. Typically, we show about 60% apples to apples savings. The same exam in the Buca plan compared to with green imaging. There's some soft savings that happen there as well, but we did a real savings report like you're talking about, and we do those quarterly, where we were actually saving 85% apples to apples because we're not sending to those hospital systems. We're sending to our good outpatient imaging centers that are less expensive. And so, in real life, we're even cheaper. And that's very interesting for us to see. Those are great case studies. We can also do geo access in advance, and we want to do that. We never want to have a group come our way. If you're accessing us through somebody else, send us your geo anyway, so that we can make sure we have facilities for those members.
Well, speaking of that, your map, I remember years ago when the map was Texas, pretty much. And you've gotten, well, yeah, you got to start where you got to start. But you now have a national map, but it is not, and this is in part because of population centers, employers who are part of the plan. Sometimes you build it and they'll come, but sometimes you got to wait till they come before you build it. But how are you seeing what's happening with your map and your network? Are you seeing growth there? Is there more receptivity on the part of imaging centers? You just mentioned hospitals are more open to partnering with you. What's the situation?
Over 5,000 facilities in 50 states is the answer. Yeah, we're growing really quickly. I have people coming to us now and wanting to join the network. And the other thing is the aggregation, the private equity groups get it. They get that we're bringing them patients without their having to do any marketing. And so as they acquire more and more imaging centers, we secondarily acquire more centers when we're working with them, hospital systems as well. So that they have been more and more as patient responsibility has risen and patients' inability to pay that has risen. They're much more receptive to working with us.
They've gone from, that's really, really interesting. They've gone from viewing you as a competitor or a discount, an unwelcome discount, to distribution. That's a big, big switch.
It is.
Congratulations on that. Another one of our mastermind partners, Rob Winfrey, has a fairly complex question. So do you see brokers creating step one bundles, cash pay bundles, and then step two, direct contracts, and step three, RBP? But could there be a step four? He said using an independent network for remote employees and satellite offices of an employer so you can accommodate them as well. And he said, especially in rural areas where access is of course limited.
Agree 100%. And that's where you have to have the financial incentives in place as well, to prioritize I kind of see the bundles and the direct contracts as being more one and the same. But where where you have those in place, that needs to be the highest financial incentive. And then RBP, because you may have some exposure there. Some may not get settled in this calendar year or in this 18-month. And you've got some liability there. And then I think backup networks can have real value, but they shouldn't be used as the default. And sometimes that's what people understand, so they use that as the default.
Well, and if you're using a wrap network of some sort, or when you've got anything out of network, RBP is of course the ideal, really your only solution, I think. Terry Shook, who is in our NextGen Mastery Track program, asks, can you expand on your thoughts around cannibalism? You referenced cannibalizing. What did you mean by that? He was wondering.
Yeah, so we were approached by a company a few years ago to basically cannibalize green imaging. We wouldn't be green imaging anymore. We would be, under their umbrella. And they have now acquired one of our competitors and are basically, as of, I think, next year, people who'd been using just that piece of the puzzle are now going to be required to use more of their services. And so, that is, and it's there, and they can't use, there's something about for 2 years, they can't, I don't know, but there's something that where they are incentivized. No, that was with a captive. They were using the competitor with a captive. But we're getting new business because, people are being asked. And this is where I think I never understood when people said every health plan is different, but every health plan is different in geography, in members' willingness to participate in change, in utilization. All of those things are really different. How many men you have compared to women, and our families included. All of these, who's enrolling their whole family. All of those things make health plans really different. And so I do think they have to be customized. That's why I really like the NextGen model, where there are multiple solutions and you customize a plan. I think that's probably, I think it's a better model than these cookie cutters where people are trying to create plans, because there are just too many complexities there, and there's services people don't need that are being included there.
Well, and especially when you get to larger companies and you can really start to manage the risk. We had a fascinating conversation. I think you'll appreciate this. We had our monthly mastermind celebration call yesterday, and Ben Connor out of Indianapolis, Connor Insurance, asked a question about are brokers ready to get granular and start to manage the individual health conditions and health data of employees? Well, the answer is no. Of course they're not, any more than most of them will adjudicate claims, even though a few like Mike Hill and a couple of others are willing to take these larger claims and adjudicate them themselves to just double check the TPA. But Ben's question flowed from, they have a new population health management solution that is part of Connor Insurance. Ben purchased it last year. Well, another mastermind partner, Daniel McCauley, who comes out of tech, he was in software sales for 10 years. He said, here's the difference I see between the tech companies and the healthcare brokerages, the healthcare advisory firms. In tech, we were both responsive and responsible because we owned the product. So we had to be responsible for outcomes. And if they weren't right, we need to make them right. But ideally, we're going to make sure we get them right in the first place, so you don't have to fix the problem. In benefits, healthcare advisors are just responsive. We're not responsible. We don't act with a sense of responsibility to managing the risk. And what I think we're seeing is a move towards let's be more granular. Not that they're going to do it as advisors, but bring in a solution
Right.
that will, let's get that patient to a diagnostic test before we know they need a diagnostic test from physical symptoms, because we've done biometric testing and a health risk assessment. We know they have a family predilection towards breast cancer. So let's go get them a screening, et cetera. So I do think we're moving, and by the way, those are health care issues, not insurance issues. Coast that comes with insurance, I guess, is risk management. So I do see some real changes there. In our last couple of minutes, Cristin, you've got a large number of brokers and advisors on here. What advice, suggestions do you have for them as they're working with companies and the company's health plans?
I would say tap into your solutions, be proactive. If you have a question, I had, a broker a couple of weeks ago that we had, the TPA was involved, but there were two different doctors ordering tests that were conflicting with each other. And she called me and she said, what can we do here? And, I actually could write an order that combined the tests. I talked to both doctors. I made sure that this member was going to get everything he needed and that the family was going to be satisfied with what they got, coordinating between this epilepsy specialist and this kind of more new age doctor who's looking at holistic care. And, I was able to do that. I think tap into your clinical resources. You all have clinical resources in these NEXTGEN plans. Use those. We're here. We're here. We're responsive. And that's again where subscription-based care comes in. You've got resources there for clinical input. I think use that clinical input. My other, really to decrease the friction, my other point is make sure your contracts and your plan design align. That's the other place we're really running into friction, and it puts the TPA at odds with your solutions. And that's another point that I think I can't stress enough. And if you need help with that, we are happy to, and we want to get in front of, because Nelson, stop loss is providing decrements for green imaging. We want to get in front of the stop loss people and show them what we can do and what data we've presented to you for savings. There are just so many things we can help you with. And I would say tap into that.
That's fantastic advice. And if you're an advisor listening, you've got clinical resources at Green Imaging, for instance, medical management, medical utilization management, AIM, they are clinical. That's their whole gig. The good PBMs, US RX Care, True RX, True Scripts, all have clinical resources. The ultimate captive that we run, single parent captive, has a PharmD as their director of solutions and provides clinical assistance. So I think that's a great, and this is how in part you do healthcare as an advisor. It's not your expertise. You're the consultant. Consult with your clinical experts. All right. Cristin, I can't tell you how much I appreciate the role you play in this movement and the solution you've pioneered with green imaging. I love counting you as a friend and a colleague in all of this. So thanks for joining us in the Healthcare Lounge, and enjoy your weekend, everyone. Thanks for being with us today in the Healthcare Lounge. We'll look forward to seeing you next month.